Wrongs Part 2 from June 21st, 2024. Starting it off with pityriasis rosea, which they describe as a cutaneous eruption characterized by an acute onset of pruritic red patch or herald patch, followed by numerous smaller papules and papules. So what they did here is they give you a picture of somebody's side, and they didn't give you a clear view of the herald patch, and there's no mention of a herald patch. All they tell you is that it's 4-week history of itchy rash, and now what are you going to do about it? And so in this particular instance, they didn't give you any steroids anyways, but if it's asymptomatic pityriasis rosea, the treatment is to just wait it out, observation, and if it is symptomatic, you can give them steroids in the interim. But it should only last, they're saying it should only last roughly 6 to 8 weeks without treatment. So just keep that in mind. They might describe it as ovoid and scaly with a rim of scale around the leading edge. And it occurs following a viral illness and has been associated at times with HHV6 as well as HHV8. So be mindful of pityriasis rosea in that way. Okay, the next one is the difference between coarctation of the aorta and subclavian artery atherosclerosis. So I thought that I had seen questions before where you could have a difference in the left and right upper extremity, but I may have misread that in the past, because according to this question, if there is a difference between the right and left blood pressures in the arms, so in this instance it was 160 over 100 in the right and then 105 over 65 in the left arm, then it has to be subclavian artery atherosclerosis, because that's apparently the only way that works. So you can use a duplex ultrasound with color flow imaging or CT angiography in order to diagnose it. And if you were to try and treat subclavian artery atherosclerosis, you would have to use an endovascular technique such as stenting or angioplasty. Okay, the next one is a pretty classic epiglottitis patient. They were leaning forward, they were drooling, they had poor blood pressure, they had a high fever, okay? And so they immigrated to the US from Afghanistan 2 days ago, and an 18-month-old boy. So you kind of knew that there was epiglottitis, but they're saying in this pretty unstable patient who has stridor heard without auscultation, what's the next best step? And I ended up picking lateral x-ray of the neck. But in reality, all that's going to do is just show you that they have a swollen epiglottis, and that's that's the symptom of epiglottitis. So you need a prompt airway protection intervention, which in this case would involve taking the patient to the operating room, not just doing it anywhere unless you really, really had to, but I don't think they would do that to you on this test. So you take them to the operating room and then actually do the procedure there. The next one is X-linked A-gamma globulinemia. And so this is caused by a defect in the Britton tyrosine kinase gene. So that in this particular instance, what you're kind of looking for was like, where the heck is being low on antibodies? And then you got distracted and you ended up picking hyper IgM. But in this 16-month-old who is having signs of recurrent bacterial infections after their 6 months of life, they need IVIG, they need intravenous immunoglobulin treatment because they have Britton tyrosine kinase deficiency, X-linked A-gamma globulinemia. And this can lead to a concurrent B lymphocyte deficit, okay? Because they're just making less antibodies. They're going to make less memory B cells, and they're also going to make less cells that actually shoot out antibodies at all. All right, the next one is going to be the treatment for lumbar stenosis. It's lumbar laminectomy. All right, they gave you all of the classic things. They said DTRs are decreased at the ankles, sensation is decreased over the feet, and it gets better when he is on an exercise bicycle. So they're insinuating when he leans forward, this 47-year-old with 6-month pain of aching, burning pain in his legs gets better when he leans forward on the bike. So for him, the treatment ends up being lumbar laminectomy. Now, I went ahead and gave them an epidural administration of dexamethasone. And that's because oftentimes the dexamethasone is given when there's CNS inflammation. And apparently, it has not been shown to improve pain and disability in patients with lumbar stenosis. So it's not a commonly used treatment for lumbar stenosis. You got to do lumbar laminectomy. Okay, for the 5,000th time, we got chronic myelogenous leukemia and leukemoid reaction wrong. So then this time, one of the main things they were looking for was that leukemoid reaction should be around 50,000 leukocytes or lower, and after a recent illness. And so they told me that they had been having fatigue for the past 2 weeks, and I took that to mean that they've been getting ill in the last 2 weeks, but that's not what they meant. And on top of that, this person has a leukocyte count of 104,000. And they also have splenomegaly. And so leukocyte counts were much, much higher than 50,000, which is already plenty high on its own, along with splenomegaly, is more likely to be chronic myelogenous leukemia, especially in this 67-year-old. Okay? Now, leukemoid reaction can definitely happen in a 67-year-old, but can happen to just about anybody. Whereas chronic myelogenous leukemia is the opposite. Chronic myelogenous leukemia is not really going to happen in a 30-year-old. It's going to happen in like a 60, 65-year-old or older, with splenomegaly and a leukocyte count sometimes approaching 100,000. All right, so the next one is, this might be the third time that you read a number wrong. Okay, so they're saying the troponin is 0.1 and the normal is 0.04. So this is almost 2.5. This is 2.5 times the normal of troponin. And then they tell you there's SD depression in V3 through V5. And you still pick acute muscular strain for no other reason than the fact that they said that it's provocative when they palpate the chest wall, which made it sound like a costochondritis muscle strain. But their troponin is 2.5 times normal. Creatine kinase is 87. So I don't know what we're doing here. I mean, we're just reading numbers wrong, and that's not going to help. You got to read the numbers correctly. Next up is ulcerative colitis. Patient with bowel sounds being decreased and the X-ray showing dilated colon and gas in the bowel. Okay, so they had already told you they were taking sulfasalazine. For ulcerative colitis, there's a different question where they had neutropenia on this, secondary to the sulfasalazine, just like the UWORD question. Okay, but in this particular case, they have a fever, they have a distended tympanitic abdomen, and the X-ray shows dilated colon and gas in the bowel wall. Gas in the bowel wall, I think, is one of the big takeaways they want here. Gas in the bowel wall. That's XLAB. Okay, we're not doing observation here like we would with an SBO in other patients. Okay, this is almost giving more toxic megacolon. All right, possible sign of bowel wall necrosis with that gas in the bowel wall. So XLAB there. Come on. Next up is 42-year-old woman. This one was actually maybe a tough one. I'm going to say of every question that we missed on this one might have been the most acceptable. Okay, it's basically saying that she had a moderate headache while she was exercising at the gym, and then the pain started in her right jaw and radiated to the right temple. Okay, no serious illness. Blood pressure is 150/90. She's awake and alert at this time. She's got a slight decrease in muscle strength, 4 out of 5 in the left extremities. And DTRs are different as well. DTRs are 2+ in the right, 3+ in the left. Babinski gets messed up as well. Babinski is present on the left, so they're saying upper motor neuron issue that's affected the left. Okay, but the pain was on the right. And what they end up wanting here was carotid artery dissection. Okay, we went with cardioembolic stroke. Very fair guess, in my opinion. Very fair guess. But the pain in the jaw and the headache was just not really cardioembolic stroke-like. Okay, so carotid artery dissection usually precipitated by minor trauma or mechanical event. In this particular instance, they're saying that the exercise was bad enough, but even vigorous coughing apparently would be good enough for carotid artery dissection. And then they have headache, jaw, face pain with some associated focal neurologic deficits. And then you're going to diagnose this with CT or, in theory, MR. But how often is that, right? So I think a good takeaway here is they had the face jaw pain on the right side, and then they had upper motor neuron deficits, focal neuro deficits on the left side. Okay, it's the opposite side, which makes sense for where the damage took place. Next up is bone cancer, 17-year-old. So ends up being osteosarcoma. It's always osteosarcoma. It's characterized by cells with enlarged nuclei, and disorganized tissue structure. Okay, so areas of osteoid production, mineralized collagen that provides structure of the bone. Just to kind of illustrate what we're seeing in the picture, you see a lot of like normal porous bone here at the junction between the femur and the tibia, but the tibia has got this much brighter, hyper contrast bone, and you can't necessarily make out why it is. So because of that, you do an MRI of the knee. You're suspicious that it's osteosarcoma. Okay, it's a 17-year-old. She's got 2-month history of pain. She has it at rest and with exertion. Okay, so that's even more so an issue of bone pain. And at this point, she's not even able to bear her full weight on that left leg because there's just too much pain. And then you have this hyper contrast, hyper white image of the tibia, and it ends up being osteosarcoma. Okay, so in this case, they wanted the initial x-ray, what they already gave you, and then they want to do an MRI so they can have clear delineation of the lesion itself, and then potentially do a surgical approach for resection or biopsy. All right, you're going to combine that with chemo. Here we have aortic insufficiency in a patient that has infective endocarditis. So they give you way too many hints that it's infective endocarditis. They're feverish. It's been lasting for 4 days that they're short of breath. They're an IV drug user, and they have splinter hemorrhages under their several fingernails. So, I mean, this is like a 3-sentence vignette, and they've already given you like 5 of the Duke criteria. All right, and then they tell you that there's a high-pitched decrescendo diastolic murmur at the third left intercostal space, and they want aortic insufficiency. And so you're sitting here saying, what the fluff? That doesn't make any sense. Why am I on the third intercostal space on the left? And it doesn't matter. I mean, it's diastolic decrescendo murmur. It's aortic insufficiency. That's what they want here, okay? It's not a right-sided murmur. They didn't give you tricuspid even as an option here, all right? They just said fever, dyspnea, new murmur, and that's bacterial endocarditis. That's fair. And then you have to know that a decrescendo diastolic murmur, best heard at the third intercostal space on the right, is going to be aortic insufficiency. And I mean, you just gotta come to that conclusion. Here you have carcinoid syndrome, that they don't give you serotonin as the thing that's getting released. They're just being jerks. They just want you to think from first principle here, which of course I did not do because I picked cortisol, and they have a blood pressure of 100/60. Okay, so that doesn't really make any sense because they're giving you the typical carcinoid syndromes. They have a non-productive cough with intermittent flushing of the face and neck. Okay, well, what kind of thing would make you flush? Well, histamine. Okay, so even though diagnostic studies of somebody with carcinoid syndrome most of the time is going to lead to urinary 5-hydroxyandilysidic acid, 5-HIAA. In this particular instance, they're not giving that as an option. So you gotta just use first principle. What kind of thing would flush your vessels? Okay, what kind of things would make you red and puffy? It'd be histamine. And they're going to just go ahead and fall back on the fact that carcinoid tumors are neuroendocrine tumors that can produce serotonin, histamine, bradykinin, prostaglandin, substance P, and chromogranin. Okay, flushing, diarrhea, shortness of breath, and abdominal pain are the symptoms, and you're going to have to treat it with surgery, radiation, or chemo. All right, that's carcinoid syndrome. Here's an annoying one. They ended up giving you somebody who's having a hard time swallowing. So we do want to do an EGD, of course, but they want to know what's the most likely diagnosis in this non-smoker who has a sensation of food stuck in his throat. And so you're figuring it's probably not carcinoma of the esophagus. They don't have any risk factors other than age. But even that was a tough thing to just say no. GERD, well, it's not GERD. They don't have actual pain. Transfer dysphagia, we've never heard of that before, so we're not going to pick it now. And we're just between Schatzki's ring and Zenker diverticulum. And they don't give you a lot of the things that you've seen in the past with Zenkers. They don't give you the halitosis, okay? They're not giving you a neck mass. They're just telling you that sometimes he regurgitates, he coughs up undigested food and pills, and he has a sensation of food stuck in his throat, okay? And they want you to take that and reason that that's more likely Zenker than it is Schatzki ring, okay? Schatzki's ring is a circumferential band of tissue that partially occludes the esophageal lumen and appears as a thin ringed defect at the barium esophagram. Patients present with intermittent dysphagia to solids. Regurgitation of undigested food is uncommon in cases of lower esophageal ring. So, I mean, that's fair. I mean, what they're really getting at here, and they make this distinction for you. They don't just say cut and dry Schatzki's ring. They say lower esophageal Schatzki's ring. Okay. Whereas the muscles that are related, the cricopharyngeus, the muscles that are related to the Zenker and that hypopharynx and those are, that's in the superior esophagus. More likely you would regurgitate that food and pills, as opposed when you're comparing that to Schatzki's ring. Next up is a 9-year-old boy, acute pain and swelling around the right elbow since sliding into home plate. What do they tell you? They say there's a distal right humeral deformity. Distal right humeral deformity, and the radial pulses are decreased on the right. What's the most likely thing that got injured here? Brachial artery. It's not an unreasonable thing. But they said, what is the greatest risk for with the following sequelae? And I guess in this case we were probably reading it too down the road. What they're saying is that in the acute evaluation of this extremity fracture with decreased pulse, that you need to keep in mind the brachial artery bifurcates into the radial and ulnar arteries just distal to that elbow joint. Okay, so he's got a decreased radial pulse, and you need to do emergent reduction and operative fixation. All right, and do 6 to 8 weeks of immobilization afterwards to allow for the fracture to heal. Okay, last one is a hemothorax, which we treated the same way that we would have treated a pneumothorax, and that's not right. Okay, in a pneumothorax, you can skip the ABCs and you can just stick a needle in them, do needle decompression, do thoracentesis, do however you want to phrase it, that you're putting a needle in there and you're getting the air out of there and you're getting it back to that negative pressure when compared to the atmospheric pressure. Okay, but in this particular instance, they're saying there was a motor vehicle crash. Heart sounds more normal. O2 is 92%. But on the left, they saw pleural effusion. They're seeing fluid on the left 25 minutes after a person was in a motor vehicle accident. Their blood pressure is 110/60. So we sort of read that to mean, well, we're probably not hypovolemic at this point. But they're saying breath sounds are decreased on the left. And the O2 is 92%, and they saw left pleural effusion, not air on the left, but rather fluid. And so then in this particular instance with the blunt trauma, what they want is tube thoracostomy. All right. They're saying that could be potentially turned into a massive hemothorax. And at that point, you need to be having a tube in there that can drain that blood. Okay. Doing a thoracentesis is not sufficient treatment modality for the patient. That's how they're going to phrase it. They say tube thoracostomy is more appropriate to remove a larger quantity of blood and can be left in place and trend and monitor ongoing bleeding within the long pleura or injured vessels. All right, that's what they want.